Evening, consultants, fellows, and colleagues on the call. You are welcome to today's presentation on cardiac transplantation, and we are privileged to have the presentation by our colleague, Dr. Julius Obilai. Kindly, Julius, your audience.
Right. Good evening, everyone. Um, Thank you, Eugene. We'll be talking about cardiac transplantation. Um, Hopefully it shouldn't be too boring. Um, so just by way of introduction, just to give us a bit of history. Um, the first cardiac transplantation in humans began 50 years ago in Cape Town, South Africa, which is good news. And it was Christian Barnard that was the doctor who performed the first human-to-human transplant. And this happened in Cape Town, 3rd of December 1967. Prior to this, about 3 years prior, someone had attempted a xenograft transplant from a chimpanzee's heart to a human heart. I don't know how that turned out. But the first human-to-human transplant was in 1967. And the recipient was an ex-boxer. His name was Louis Washkansky. And he had end-stage ischemic cardiomyopathy as the indication for his transplantation. And 3 days just after this, the Americans picked up steam, and they had the second human heart transplant done in Brooklyn by Adrian Kantrowitz, a cardiothoracic surgeon. And the recipient in his own case was an 18-day-old, not 18-year-old, 18-day-old neonate who had Epstein's anomaly and then refractory heart failure from this, and had previously had a shunt for severe cyanosis. Bernard again performed the third transplant. This time around, it was more successful, as he was the longest survivor in that time, having lived for 18 months after his transplantation. And this was done on a 46-year-old dental surgeon. So it was a colleague he had this done on the second time, or the third time rather. Um, so after the initial very rapid growth of this procedure in the United States, it kind of stopped. And as a result of the poor outcomes, they had a very abysmal survival rate of about 20% in the first year. And so most centers, they closed, they ceased the transplantation program. But again, subsequently, there came an uptrend in things. A gentleman, pathologist, Caves, and his colleagues, they described the method of transvenous endomyocardial biopsy that helped to monitor allograft rejection on a serial basis. This accounted for the poor outcomes, basically, the rejections that were ongoing, which they were unable to monitor and do anything about. Subsequently, in 1984, cyclosporine came about, um, and this immunosuppressant also helped transplantations pick up with better outcomes. This is the gentleman, Christian Barnard, and he appeared on the cover of Time magazine in 1967. And that's the organ just above there that causes all the trouble. Right, this was his team. Um, yes, so cardiac transplantation is basically defined as a procedure whereby the heart of a suitable donor is implanted into a recipient. So what are the indications? ACCAHA, they've listed out some indications. So patients with refractory cardiogenic shock requiring intra-aortic balloon pump, counterpulsation, or a left ventricular assist device. Patients in cardiogenic shock who require continuous intravenous inotropic therapy, such as either dobutamine or milrinone. Patients with a peak um, VO2 max less than 10 mils per kilogram per minute. Patients with New York Heart Association class 3 or 4, despite optimization of their medical therapy and where indicated resynchronization therapy, but all these measures have failed to optimize the patient clinically. and otherwise. Patients that have recurrent life-threatening left ventricular arrhythmias despite ICDs, antiarrhythmic therapies, or even catheter ablations are also patients that are put on the transplant list. And patients with end-stage congenital heart failure with no evidence of pulmonary hypertension. And then those with refractory angina without potential medical or surgical therapeutic options. And this is actually quite similar to what I've just. So how do you evaluate a patient with heart transplant? There's a lot that goes into evaluating these patients, basically. Um, and Basically starts again as we know the clinical history, the physical examination. You want to confirm this patient's symptomatology is in keeping with heart failure. Examination as well. You want to confirm the diagnosis. You want to assess the patient. Look out for rule out other end organ damages that may be a contraindication for heart failure, or that may require double organ transplantation where feasible. You want to assess to look out for any latent or active malignancy that may disqualify the patient from this. You also want to exclude latent infections that may be reactivated when you start off immunotherapies. That's why you're checking the CMVs, the VDRL, tuberculosis. You want to do an ABO resource blood type because this will also be necessary for your cross-matching. You want to assess the patient's pulmonary function test. You also want to do, of course, an ECG and then a right and left heart catheterizations. And then you also want to assess the patient's cardiopulmonary exercise testing. Where it's less than 10 mils, those are the patients actually indicated for transplant. Of course, each appropriate malignancy screening is also recommended. You want to be sure that the patient you're giving this rare organ or this scarce organ has an appreciable life expectancy that's not going to be limited by any other condition. So you want to also do a psychosocial evaluation. This is quite interesting because patients that do not have substantial social supports are actually not included in the transplant list. If they don't have enough social supports in terms of family, close friends that are going to actually be as a support system for this patient may not um, enter into the list. And of course, patients with substance abuse history, mental health disorder patients, this is just because some of these patients may not have the motivation to take those immunosuppressants that will end up being lifelong. Financial screening is neither here or there. Why is the decision-making process important? So basically, the decision on transplanting a patient and also selection of the patient, there's a lot of ethical and legal things all around this. And so it's usually done by a team. There's a very, very comprehensive team involving the cardiologists, the surgeons. There are senior nurses involved as well. Occupational therapists, there are immunologists involved. Such a big team. The supply of organs is inadequate. Also, the allocation of a donor heart to a patient with relatively better prognosis will deprive a more seriously ill patient with a short life expectancy, but a preserved non-cardiac organ function, the opportunity for transplantation at a time when his or her benefits will still be maximal. So these are also some considerations that are taken in. Also, we know that the cardiac transplantation in itself is not completely curative because there are also other chronic morbidity and survival limitations associated with cardiac transplantation. So, and that's why it should not be offered to patients with either intermediate or long-term survival approaching that of transplantation. Basically, you want to be sure that the patient that is going to be given these hearts has a very high survival chance. These images, hopefully, they are not too unclear. So there's actually a categorization of patients that are on the transplant list, and they are prioritized based on several factors. The first category, status 1A, are patients who require mechanical circulatory assistance with one or more of the following devices. Either they are currently having a total artificial heart, or they have either a left or a right ventricular assist device implanted for 30 days or less, or they are requiring an intra-aortic balloon pump or an ECMO. So these are patients that are on top of the list, while those that require mechanical circulatory support for more than 30 days with significant device-related complications. So basically, these are next on the list. These people that have significant device-related complications from their MCS at higher mortality risk. And those on mechanical ventilation come next, while those with continuous infusion of high-dose inotropes, in addition to continuous hemodynamic monitoring of their left ventricular filling pressures. And those with a life expectancy without transplant of less than 7 days. The next category are those with an assist device more than 30 days and those with continuous infusion of intravenous inotropes, but not high dose as we have in the first category, and are not requiring continuous hemodynamic monitoring. All other patients will fall into status 2. Again, I hope this is not too unclear. How do you approach a patient for potential? So when the team actually receives the referral, they basically do not take everything hook, line, and sinking. From what is referred to them, they have to assess the patient themselves. They want to be sure that there are no other potential reversible causes in these patients. Their heart failure, like a valvular disease that can be repaired, um, or any other cause that is potentially resolvable. They want to evaluate the severity of the heart failure and the functional capacity of the patient. Usually a 6-minute walk test or a VO2 max is used to assess that. They want to ensure that adequate patient medical therapy has been optimized and also other device therapy were indicated. They want to assess the patient's risk of deterioration or sudden death, which may push them higher up on the list if accepted, and they want to identify indications for transplantation. Of course, they also need to exclude the contraindications to transplantation. Where these patients eventually meet all the criteria, they still keep following up the patient to ensure that their heart failure management is evaluated and optimized periodically. So those patients who are referred for refractory heart failure, the A parts, just looking through this now. So they are going to be looking out, of course, we've said all this. You want to look out for reversible causes, you want to optimize medical therapy. And the next question to ask is, are they inotrope dependent? If they are, of course, seen by the fact that their blood pressures are low with some early end organ damage. These are patients that are immediately accepted to the transplant list. Or where indicated, they may have to be put on a mechanical circulatory support like a VAD, LVAD, whilst as a bridge with destination therapy. Or if there are patients who, for any other reason, do not meet the transplant list, either because there's an active malignancy or there's already an end organ damage and they are not candidates for double organ transplant, you're just probably going to palliate such patients or what they call an end of life care for them. But if they are not inotrope dependent, what they do basically is to, and if they're ambulatory, they assess their their VO2 max. There's a C2 heart failure model calculator that they also use to assess their functional capacity. And then the heart failure survival score is another method of assessing these patients. And coming on down here now, if their VO2 is less than 10 or on their CR2 heart failure model calculator, it's less than 80%, or they have a medium or high risk of death on the heart failure survival scale, they are listed for transplants. If none of these are met, they are deferred from the transplant list. However, they are still monitored continuously. But there's a gray zone basically for these groups of patients. There are some factors that could increase the morbidity and mortality after cardiac transplantation. So basically, all these are looked into quite keenly so as not to all these are assessed prior to transplantation, basically, so as to properly categorize patients who get the most benefit from transplantation. You want to be sure that you want to assess um, to know what their pulmonary arterial pressure are. Patients with pulmonary hypertension, basically, they have increased morbidity and mortality following transplantation. Also, similarly, patients with end organ disease are irreversible, either liver, kidneys, or lung end organ damage. Patients who have had recent pulmonary infarction, patients greater than 60 years, or those who are diabetic with macro microvascular complications. Also, there are some gastrointestinal patients with active hepatitis, diverticulitis, and all this is also because of the fact that they're going to be on long-term immunosuppressants, basically. Initially, they'll be on steroids, which could worsen their ulcers, and they're going to be on immunosuppressants, which can reactivate their viral hepatitis. Patients with malignancy within 5 years are also at high risk. Patients with psychiatric disorders and substance abuse disorders, and also those who lack social support. These are patients with increased risk of morbidity and mortality following cardiac transplantation. Contraindications, active infection, HIV positive patients, like we know again because of immunosuppressants, active peptic ulcer disease or chronic active hepatitis, patients with diverticulitis, all these conditions which carry increased risks if their immunities are suppressed. And like we've mentioned, diabetes patients with macrovascular complications, those who are morbidly obese as well, those with mild to moderate chronic kidney disease, and those with bilirubin higher than this value and it's not attributed to hepatic congestion, those with severe pulmonary dysfunction as assessed by the spirometry, um, those with acute PE, and these are other very many other contraindications generally. But there are absolute contraindications that we should also be aware of. Patients who have a systemic illness with a life expectancy of 2 years despite heart transplant, including active or recent solid organ or blood malignancy within a 5-year period, such as leukemia, low-grade neoplasm, or a prostate cancer. Of course, patients with AIDS, you probably can't give them immunosuppressants, so there are absolute contraindications. Patients with other autoimmune conditions for the same reason. SLE, sarcoid amyloidosis, multisystem involvement, and is still active. Patients with irreversible renal or hepatic dysfunction, and patients with significant obstructive pulmonary disease. Also, patients with a fixed pulmonary hypertension with these values are absolute contraindications. How do we select the donor? It said that brain death is a hostile environment for the donor hearts. Undoubtedly contributes to the occurrence of primary graft failure. So proper donor selection is it's important. These are all the things that are looked into. So a patient who is brain dead and who is a candidate for transplant and are giving his approval prior to hand, the organs are not just recovered from these patients. There are a number of things that are assessed in the patient as for transplant before the organs are recovered for transplantation. The time of death, they want to know the patient's age. All of these risks, basically, they increase either the risk of primary graft failure, um, like age less than 50 carries a normal risk, a low risk, compared to an age greater than 65. They also want to assess the patient's circulatory parameters at the time of brain death as well. um, Patient requiring dopamine, what dosage does patient require? Patient requiring adrenaline. They're also going to be checking the central venous pressure. They're going to do an ECG on the heart before it's recovered to be sure there's nothing to suggest a previous infarct. Looking at the Q waves, the ST segments, the bundle branch. They're also going to do an echo on the heart before it's recovered as well. Want to assess certain parameters, basically, that either increase the risk of a primary graft failure for these patients, such as patients with ab initio low ejection fractions or very thickened septums, or they're already having regional hypokinesia, or they're already having some valvular abnormalities. So all of this is done in the patient before the organ is recovered, and they need to meet the acceptable criteria before. They also go around a coronary angiogram for these patients to also assess the coronary arteries. They do a troponin, procalcitonin, so quite a lot is done for the donor prior to transplantation. So based on whatever of this is found, there are a number of management for this donor. Sorry again if this is not very clear. So you want to, so this patient who is brain dead, who is on circulatory support and ventilatory support, they are going to be looking at the central venous pressure and try to maintain it within a narrow range. They want to correct any acidosis that's in this patient. They also want to correct hypoxemia. All of this is just to maintain as much as possible adequate oxygenation and circulation to the pre-harvested heart. They want to correct anemia. They're going to adjust the inotropes in order to keep the mean arterial pressure greater than 60 millimeters of mercury. Of course, they're going to obtain an initial echo. And if at this point the ejection fraction is more than 45%, they proceed to recover the organ for transplantation. However, if the ejection fraction is less than 45%, they need to optimize these patients. They do this both by giving hormonal resuscitation as well as other circulatory resuscitation to this pre-harvested hearts. They use triiodothyronine at this dose. They use vasopressins and they use methylprednisolone. They also give some insulin to these patients as well as a way of hormonally resuscitating the heart. And also they want to maintain circulation using inotropes such as dopamine or dobutamine with these targets circulatory parameters in mind: mean arterial pressure greater than 60 millimeters of mercury, and the capillary wedge pressure of 8 to 12 millimeters of mercury. After all of this is done, they reassess this patient, and if he meets the criteria, basically the heart is recovered for transplantation. However, if this criteria is not met, they do not proceed with recovery of the heart, so patient is allowed to rest. Matching donor and recipient, as well as ischemic time, is basically the time after the recovery of the heart to when it's being transplanted. It's a very important factor in transplantation. It also takes into account the transportation between the. So if a patient has a well-matched donor, but he lives too far off, that will increase the ischemic time to more than 4 to 6 hours. Even though he's higher up on the list, he's going to be pushed down. Because there's no point taking 8 hours to get to him, and then ischemic time is exceeded and there's primary graft failure. So these are also some of the things that they try to minimize the ischemic time. The time of the surgery is also taken into account with regards to the ischemic time. And of course, the immunology and all of these immunological stuffs are done: ABO, blood typing, the panel reactive antibodies. They're also going to match the donor's weight to the recipient's weight. And it should be within this ratio of 75% to 125%. And this is actually for anatomical reasons. You can't put a very big heart into a small mediastinum. So that's also taken into account. And like we said, the geographic location relative to the donor and the length of time at the current status. We mentioned some of this. The matching is based upon the ABO blood group, the blood size, compatibility, and it's matched against the panel reactive antibodies. And then the waiting, the priority, recipient's priority on the waiting list is also taken into account. And of course, we've mentioned the geographical location from the donor so that the ischemic time of the heart is not exceeded. So even those that this, so the degree of sensitization of cardiac transplant recipients is most commonly assessed by testing the sera of prospective recipients against a panel of lymphocytes called the panel reactive antibodies. So this actually affects the risk of hyperacute rejection, because the pre-existing antibodies in the recipient are tested against the donors, antigens, and where the PRA, where the sensitivities, where the PRA is higher than 10%, the patient is considered to represent sensitization. However, this does not exclude, this increases the risk of hyperacute rejection, but it doesn't completely exclude the patient from transplantation because there are desensitization measures that are taken for such patients. So elevated PRA titers, the pan-reactive antibody titers, are found more frequently in patients with a history of like we know, multiple transfusions, previous allograft transplant. He's had a kidney transplanted before, or he's had a liver transplanted before. He has a higher risk of PRA titers in him, and in multiparous women for reasons I'm sure we all know. Elevated PRA has more recently been identified in patients with VAD, that's ventricular assist devices. So when I say for reasons we all know, it's because the children also that the patient that the mom has increases the hormonal or wherever in the body. Okay, the mechanism responsible for the increased production of HLA antibodies in VAD patients is likely multifactorial, and it includes T cell deregulation with prominent B cell activation. So recipients of VAD who do receive blood products may become fully sensitized because of an immunological reaction on the blood-VAD interface. So there are desensitization therapies, like I said, recipients that have a high amount of pre-existing antibodies against the recipient's antigens at high risk of hyperactivity rejection, especially if it's greater than 10%. And so there are desensitization therapies that are done. So one of the commonly reported regimens consists of treatment with IVIG, intravenous immunoglobulins at this dosage. Plasmapheresis as actually to reduce these auto antibodies in the recipients can actually be carried out. So what are the techniques of surgical transplantation? I'm not sure this is probably not so relevant for us as physicians. But just to note that there are different surgical measures for these patients. There's the orthotropic and there's the heterotropic. These are the two standard operations for performing heart transplantation. The orthotopic one is one in which the recipient heart is excised and is replaced in the correct anatomical position by the donor heart. So that's what they call the orthotropic. The recipient's heart is excised and replaced. But there's another way, what they call the heterotropic. It's also known as a piggyback kind of heart transplant, in which the donor heart is placed in the right chest alongside the recipient organ. So you have both the new and the old together, and it's anastomosed in such a way to allow blood to pass through either or both hearts. So that's the heterotropic. You have both the recipient as well as the donor's hearts side by side. Either of them, both of them have their advantages and disadvantages, and there are different approaches to this, which I don't think it's helpful for physicians. So it's important to carefully plan the entire operation to attempt to limit the donor ischemic time to less than 6 hours and preferably less than 4 hours. So just in case it's in MCQ, most ideally is 4 hours. Ischemic time should also be limited to around 4 hours or less in situations where the donor heart is. So if you're already having a donor heart that is already at high risk of primary graft failure for other factors, like it's from an older donor, a patient already has prior pulmonary vascular resistance, you want to also further reduce ischemic time to reduce the risk of primary graft failure. So like we mentioned, the orthotopic heart transplant approach are two techniques. It involves both the bicaval and the bilateral. The bicaval technique preserves the normal atrial morphology, sinus node function, and valvular function. So what's the result of that? It has consistently been associated with a decreased incidence of atrial arrhythmias and the need for permanent pacemaker, because it preserves the normal atrial morphology. However, the potential disadvantages include increased ischemic time. So it's a surgery that takes a longer time. And so the ischemic time is increased and the possibility of narrowing the caval anastomosis The most common reason, whatever this means, I don't know. The most common reason for failure to win a heart transplant recipient from cardiopulmonary bypass is right-sided heart failure, evidenced by low cardiac output despite the rising central venous pressure. The other one has been the traditional one that has been used, the heterotropic heart transplant. It involves a donor heart being connected in parallel with the recipient heart. So it involves four surgical anastomosis at all these levels. So what's the advantage of the heterotropic where you have two hearts together, the old and the new? So the native heart can function as an assist device and usually can maintain circulation during either recovery of donor heart function from ischemia sustained during transplantation. It can also help during severe rejection episodes. If the patient is having an acute or hyperacute rejection, whilst that is being treated, um, his primary heart basically could still help to some extent maintain circulation. The period of adaptation of a small donor heart to the demands of the circulation is also helped by this technique. The period of adaptation during the PVR, pulmonary vascular resistance, decreases after transplantation, and the period of chronic rejection. So these are all the things um, that are helped by this technique. So what are the disadvantages where you have this old and the new together? There's a continuing risk of embolic episodes originating from thrombi in the poorly contracting native left ventricle, because we all know that this heart, basically, the reason why it's being replaced is that there's a lot of systolic dysfunction, basically, and that still increases the risk of embolic episodes. Angina, which may be secondary to persistent ischemia in the native myocardium, may be an ongoing issue for the patients. Functionally significant, just because of the technique, basically, there's a risk of ongoing lung infections and atelectasis. So what's the physiology of the heart after it's been transplanted? There's cardiac denervation. It's an inevitable consequence. The atrial remnant of the recipient remains innervated, but no impulses with cross the suture line. As a result, the donor atrium is responsible for heart generation. It has an intrinsic higher rate and reduced variability. The resting heart rate is usually between 90 to 110 beats per minute. And if the patient goes into bradycardia, atropine will not help because the heart is already denervated. Normal responses to change in position, example, orthostatic changes are lost. Also, the stimuli to vasal maneuver. This is because all the sympathetic and all the autonomic innervations are, this transplanted heart has been denervated from all the autonomic chain, and so orthostatic measures, also Valsalva, it's not going to have any effect on the heart. Intrinsic functions such as cardiac impulse formation and conduction are intact. Also, the Frank-Starling mechanism is also intact. The denervated heart, however, the initial response through the Frank-Starling mechanism is an increase in stroke volume dependent on adequate left ventricular end-diastolic volume. And the increased contractility secondary to heart rate is a secondary effect. So these patients basically are critically preload dependent. They require higher filling pressures to maintain their stroke volume and their cardiac output compared to their heart rate. What's primary graft failure? So primary graft failure after heart transplant is the presence of severe mechanical dysfunction without obvious anatomic, surgical, or immunological causes, such as a hyperacute rejection. So like we say, it's mainly based on the ischemic time. Primary graft failure, it has been invariably defined in the literature as heart allograft dysfunction requiring two or more inotropes, or the need for mechanical circulatory support, either with an intra-aortic balloon pump or a ventricular assist device within the 24 hours of. So it occurs quite quickly, but then there's really no immunologic mechanism to it, and it's not because of the technique of the surgeon. It's because it's just basically saying that this heart had already been deprived of so much blood and oxygen prior to the transplantation that the heart had already almost died before transplanting. So within that period where you recover the heart and you establish circulation, including transportation and the duration of the surgical procedure. Um, that's what contributes to a primary graft failure. So just go because time is immunosuppression is another major issue in cardiac transplantation. As we stated that when we started initially, um, the whole procedure was stopped for a period of time just because of um, s- very poor outcomes, or most of all attributed to um, graft failure from immunosuppression, um, or rather from rejection, rather. Not until cyclosporine and endomyocardial biopsies were introduced that cardiac transplantation again picked up. So it's basically one of the mainstays. Um, so that's why they make sure these are patients that are mentally sound and are willing to take medications for life and also have good social support. Because basically they're going to be having to come to for follow-ups, they're going to be taking medications for life and many other instructions they are giving that they need to comply with. So um, there are three situations that require specific combinations. The outset, there's an initial high dose of immunosuppression to facilitate graft acceptance and to minimize the chance of early rejection and potentially favor induction of tolerance. There's also the maintenance therapy for chronic acceptance of the allograft, and there's the augmented immunosuppression. Um, so if patients have acute episodes of rejection, there's the augmented immunosuppression. Um, so the induction therapy generally involves one of two approaches. Um, these are the medications, daclizumab, aciliximab, they block the interleukin-2 receptors, and there's this anti-thymocyte globulin or AKT3 that targets T cell receptor. And what's the rationale for induction therapy? It's in order to provide more intensive immunosuppression at the time when the alloimmune response is most intense. That's just within the first few days or weeks of transplantation. How do they maintain immunosuppression? Three medications, basically steroids, calcineurin inhibitors, and antiproliferative drugs are used. So there's rejection that could occur following transplantation. And there are three types: the hyperacute, the acute, which is either cellularly or humorally mediated, and then the chronic rejection. What's the hyperacute rejection? This involves the abrupt loss of the allograft function, and it can occur from minutes to hours after circulation is reestablished in the donor heart. Um, and it's mediated by pre-existing antibodies to allogenic antigens, and that's why these patients they go through the whole panel reactive antibody screening, and also sometimes they are desensitized just to reduce the risk of hyperacute rejection. The fixed complement that occurs leads to um, thrombosis within the vessels and then graft failure that subsequently occurs, either at the microcellular or macrocellular level. There's an acute cellular rejection that could also occur. This most commonly occurs within the first week to several years after transplantation. The prevalence of about 40% during the first year after surgery. And it's mediated through via mononuclear inflammatory response, predominantly lymphocytes. What's the key events? There's an initiation and coordination of the rejection response. It's all T cell activated and driven and is moderated by interleukin 2 and cytokine. So what's the gold standard? Is possibly another MCQ question. What's the gold standard for diagnosing acute rejection? The gold standard is endomyocardial biopsy. Although there are other things that have been assessed, like ECG analysis, cytoimmunologic monitoring, and a variety of radionuclide techniques have been investigated. Echo, however, is a primary modality other than EMB that is routinely used for rejection surveillance. So if you have a transplant patient that somehow um, comes in unwell, getting breathless, SST, and somehow all these patients that have been transplanted, they are very regularly in contact with their transplant team. So wherever they are in the world, they have a direct number to their transplant team. And they also encourage whoever physician is looking after them to always, even if they come in with just diarrhea or they come in with just an upper respiratory tract infection, wherever they come in with, transplant patients generally, especially for cardiac transplant, wherever they are in the world, whatever illness they come down with, it's always good practice to speak to their transplant team. Um, so when acute depression or systolic function is observed without another clear identified cause, um, they are treated basically even before confirmation with endomyocardial biopsy, they are treated um, as a possibility of acute rejection. This is not very clear, I'm sorry for that. But this is usually what's done for these patients. Um, if they are considering acute rejection for them, they need to start high dose methylprednisolone 1 gram IV daily for 3 days. They need prompt inotropic support. If the cardiac output is depressed, as evidenced by a low ejection fraction, we need to place them on a Swan Ganz catheter to monitor them hemodynamically. And they also need prompt plasmapheresis. So all these, so that's why whenever they are ill, before even they start deteriorating, they need to be, their transplant team needs to be contacted immediately. Um, all right. There's also the chronic rejection or late graft failure. It's an irreversible gradual deterioration of graft function that occurs in many allografts months to years after transplantation. Current concepts suggest that the donor had dysfunction in the chronic stages of maintenance is either related to chronic rejection or by antibodies. The other complications that could arise because these patients are on immunosuppressives, which are very, very um, potent immunosuppressants that can reactivate infections or that can exacerbate what would have otherwise been a mild or minor infection. And infections, they cause approximately 20% of deaths within the first year after transplantations. So they continue to be a common factor, both that contribute both to morbidity and mortality in these patients. Aside infections, what are the other complications? Diabetes, which you can understand because they're on steroids, they are calcineurin inhibitors. Hypertension could arise as a result of calcineurin inhibitors. Similarly, calcineurin inhibitors could also contribute to renal insufficiency. Cyclosporine could cause hyperlipidemia. Malignancy could also be as a result of being on chronic immunosuppressants. Right, so thank you for this. So in conclusion, basically, cardiac transplantation has come to stay. I think following the initial downturn, there's now a rapid uptick in cardiac transplantations. However, the main limitation is related to the availability of proper organs to organ donations, basically. But most patients that meet this criteria should be referred early for considerations for cardiac transplantations. Um, Thank you very much for your time and attention.
Thank you very much, Julius, for such an excellent presentation and your calm voice as always. We are grateful. You took us
You're welcome.
through the history. You brought us to the indications, how to evaluate a patient before cardiac transplant, and you took us through the importance, things to do before the transplant, and things that can improve the outcome, and took us through all the various surgical techniques, though you didn't stress much on it, which I agree with you. And you took us through rejection and you brought us home safely. We are grateful. Thanks once again. At this
Thank
point,
you.
ask for contributions, questions from members of the call. Then afterwards, we'll go to our consultants on the call to give us their contribution. Thank you. So please kindly unmute and ask your question. Okay, Julius, whilst we wait for questions to be asked, there was a question with respect to donors. A donor with brain injury and chest injury. Of the two, which one would be preferred?
A donor with brain injury.
Let's say, yes, brain injury or brain trauma compared to chest trauma. Which of them would be preferred as a better donor?
Uh, I didn't come across that, but roughly, if I'm to give a test, it's basically going to be patients with brain injury. Because basically it's patients who are brain dead that you want to harvest their organs. Patients with chest injury, you don't want to, you're worried about, I think what you'll be concerned about is if there has been a mechanical injury to the heart as well. That's just my general thoughts basically. But I didn't run into that while preparing for this.
I think it was in one of the recalls or something that we were solving. That was one of the questions. Thank you very much. But we also thought the correct answer would be brain injury.
Hmm.
Okay, thank you very much. Please, any contributions, any questions? Okay, let me see. Dr. Joe, hello, sir. Good evening.
Good evening. Good evening, Dr. Eugene.
Good evening, sir. Please, any contributions, pointers?
Um, Not really. I think he has touched different aspects of what should be just for emphasis. Those time, food ischemic time, non-ischemic time, and those time that are required can be important. I remember there was a time Dr. Okopi posted some of this time on the group. I don't know if anybody can find it, just to revise them because of MCQ. By and large, apart from that, I think it's well presented.
Okay, thank you very much. Let's show appreciation to the presenter. Once again, Julius, thank you very much. I know you were ready to present on the day that you were scheduled, but I had to push you to today, which was not the preferred. But I'm grateful for your understanding.
Yeah, it's okay. Thank you.
All right, so we are done with the presentation, and we're going to continue with some vivas for the candidates, where we encourage as many seniors, consultants who can stay on to guide us, and also colleagues who can stay on to guide and contribute to stay on. Thank you very much. So, Charles,